The concept of looking at ostial chronic total occlusion CTOs is important because these, while CTOs are hard, the ostial subset is particularly hard. And that is because when one is trying to get going antegrade or forward, there's not a lot of room for a guide and support. And there's some particular CTOs that are truly flush occluded. There is no space to actually land antegrade equipment. Because of that, what is already a hard procedure could become harder. So working with Dr. Berlakis and colleagues, and we contributed at Mass General, our patient population, to this prospective, through this observational registry, we studied our patients who do have ostial lesions. Now, ostial lesions are typically defined to be within 5 millimeters, that the 100% blockage is within 5 millimeters of the start of the artery. So there is a difference between something that's 5 millimeters away and truly flush occluded. That part was not teased out, but about 17% of our patients qualified in the whole registry as having ostial CTO lesions. And the really important conclusion was that there was excellent efficacy and safety, that it was similar to non-ostial CTO lesions. And that is really important because with increased complexity, we often think that we might have lower success rates and or higher complication rates, but we did not see that. These are caveats of registry studies, so it's not randomized our ostial CTO patients with a certain strategy. We did notice that, and this is typical, that when you do have trouble seating your guide antegrade or working with these flush or ostial occlusions, that you often need to use the backwards technique, the retrograde technique. And that's critical because you can attack the total occlusion from the backside and make progress and ultimately connect. You rely on that more because it's hard to get going antegrade sometimes with ostial CTOs. The nice part of this registry, and again, just registry data, so we do need confirmation in more prospective observational trials and ultimately randomized trials, is that the retrograde approach is typically associated with more complications, but yet the overall complication rates were similar here. So I think that people in this registry are doing a good job, probably skilled at retrograde approaches, and are able to maintain good efficacy and safety rates.